Good afternoon and welcome everyone. We're so glad that you could join us for our first ever virtual College of Arts and Sciences Bulls in Action Alumni Speaker Series. It's a pleasure for us to host alumnus Dr. Jason Wilson today. We're going to have an interdisciplinary conversation to address COVID-19 that is on everybody's mind. A couple of quick housekeeping items for you. We are going to have a question and answer session later in the program about halfway through the hour. If you want to ask a question or post a comment for Dr. Wilson, please choose the icon with a question mark and type your question into the chat box. You can also like a question that's already been asked, and we'll know which questions people really want answers to. We'll do our best today to get through all of them. If you see a message pop up on the screen that says the live event will resume in a moment, please be patient and we will return momentarily. We so appreciate you joining us for this conversation today. We thank our dear friends and donors of the college. We hope that you're all well and safe. Your support means a great deal to us. Before I introduce Dr. Wilson, I want to take the opportunity to just give you a quick update on what's happening in the college and at USF. As you might imagine, the university has gone through some drastic changes in our daily lives in response to the pandemic, and of course the college is no exception. All of the faculty have been working 24/7 to transition students to a virtual environment, and it's been going well. Enrollments for the summer and fall are very strong, and our real primary goal is to not stand in the way of letting our students progress with their education and to offer high quality education, even in online format. It's been interesting. A lot of us were very apprehensive about this technology to begin with, but we found out that there are actually a lot of advantages to doing this work that way. During this time, we also released the annual report of the college. If you go to our website, you can read the annual report. Lots of exciting things happened this year. We finally increased our retention rate for freshmen to 90%, which means that freshmen are coming and they're staying. We've also opened some new centers. The one I really like to mention is the Center for the Advancement of Food Security in Healthy Communities. This center is trying to change the conversation around food insecurity using research and education. We're working closely with Feeding Tampa Bay, and actually next week we're having a mega food pantry at the Sundome, the Yingling Center, to try to do our part to address food insecurity. So that's been extraordinary. All of this is to say that all the different portions of the college, the humanities, the social sciences, the natural sciences, have been completely tuned in to working with the community during this incredibly stressful time. And I appreciate all of your support and your attention to this work as we do it. So let me introduce to you our speaker for today. This is always so exciting to bring back folks who are graduates of USF who've gone on to do amazing things. I've stayed very close with Dr. Wilson, and he actually has been educating me about COVID through his social media posts and also our conversations. So let me tell you who he is, and then we'll get the conversation going. So Jason Wilson is an emergency medicine physician. He graduated from USF with a bachelor's degree in anthropology, got an MA in anthropology at University of Michigan, and then returned to USF for medical school and residency training in emergency medicine. He's medical director of the clinical decision unit at Tampa General Hospital, as well as associate director of the adult emergency department. He also has an appointment in internal medicine in the Morsani College of Medicine and a courtesy faculty appointment in the Department of Anthropology and Arts and Sciences. Over the past 4 months, Dr. Wilson has been a member of the TGH COVID Task Force, and he's involved in the day-to-day operations and clinical treatment of patients with COVID-19. One last thing, just a more personal note, Jason teaches a course every year with our own Professor Robbie Baer that works with undergraduate pre-medical students to provide early training in patient-centered care. It's a unique approach that combines social science and anthropology with medicine and patient shadowing. They expose these students to qualitative research, and they help get the students off on the right track, thinking broadly about clinical work and the role of medicine within the broader social context that is provided. So without further ado, I want to introduce you to Dr. Wilson, and I think I want to do that by sort of asking a general question that will give you a sense of what he's all about. So Jason, you have such a unique background, and I so appreciate. Would you mind telling us a little bit about how you have managed to combine your medical training with your USF anthropology training, and how does this unique combination affect the work that you do every day in your role at Tampa General Hospital? Jason, I can't hear you. Can others hear you?
Okay, I was muted. I'm off.
Ah, there you go.
Yeah,
welcome to the world of Teams.
Yeah. Yeah. So Eric, that's a really good question. I wanted to say thanks first for just having me here and for having me as the first virtual Bulls in Action speaker. I feel like it's appropriate because I think if I'm not doing patient care, this has become my virtual sort of studio here. Just Teams all day and Zoom all day like everybody else right now, I think, and it's just the world we live in right now. So your question is very good. It's one of those kind of questions where I think before this pandemic, people could have asked me this question and you might struggle to find an answer. Why do you combine all these things? Where are you trying to go with this? And in pre-pandemic life, you had to kind of think about how to answer the question, sort of structure the answer, unpack it a little bit. But now in peri-pandemic life, I guess you could say, during this pandemic, it seems so obvious. One portion of what I do is take care of patients, and that's hey, I need medicine training, I need this medical side of things. But so much of what I do right now is try to understand this system that we operate in. So why do our patients get COVID? Who gets COVID? Who doesn't get COVID? What are the social forces that are leading those patients there? What do we do with them when they get there? We can't admit everybody to a hospital right now. We saw what happened in New York City. So we know we've got to come up with some community strategies, community partnerships to get everybody involved in helping take care of our patients. How do we communicate as a healthcare team across teams? Eric's, I know your work is a lot on communicating healthcare teams. So you've seen the challenges of just communicating in emergency medicine. Now take that challenge of communicating within emergency medicine and begin to scale that up. I talk to my ER doctor colleagues, but now I also spend a lot of time talking to other hospital administrators. I talk to people who have a lot of medical training, people who don't. I talk to people outside of emergency medicine who are infectious disease experts. I have to be able to communicate those things, those people. And what I think about a lot of what I do right now is really understand the medicine, learn the medicine, because it's changing all the time with COVID right now. There's new medicine going on all the time. Think about where our gaps in care are, try to work medically and interdisciplinary teams to solve those gaps, but then also try to find interventions that are going to help us treat and move patients throughout the healthcare system. So scaling up and doing organizational change is a big part of what we're doing right now. So that's sort of the description of the what, and so I think it becomes more obvious to how a broad background in liberal arts education and specifically in social science and anthropology education, has really paid off. Right, this is a force that we're seeing, a pandemic that we're seeing that is affected not just by the biology of the disease, but also a number of historical and social forces. And so I think having somebody sit at the table who just understands we're going to have to build pathways that address all of those pieces of the puzzle has been pretty beneficial for the hospital and our patients in this area.
Jason, it's interesting because a lot of people, I think the story is that a lot of people go into emergency medicine because they like the adrenaline and they like, saving people's lives, and they don't necessarily aren't looking for a long-term relationship, right, with a patient. And that's not the nature of the work. But what this has really drawn you to do, and this kind of in your nature anyway, is to think about what is the patient's life before they came in, what's their social milieu, how are they living, and what happens when they leave you, right? So in a way, it's caused you to focus even more on the sort of social context of that patient's life, right?
Yeah, emergency medicine is interesting right now. It's even pre-pandemic, it was at a pivotal time where what emergency medicine is really changed. So I think a lot of us may have a view of emergency medicine, whether it's from the show ER or it's just from a personal experience or it's from a myth, about emergency medicine. We kind of thought it as only an acute encounter. And certainly that's part of why I love emergency medicine. I do enjoy taking care of people at their sickest when they need a lot of medical intervention. I do, find that to be a very appealing part of the field. But what's really changed is I think everybody understands our healthcare system is going through massive shifts right now, and has been for the last over a decade now. And what we've recognized is that especially a field like emergency medicine that touches every piece of the healthcare system, really sits as the hub of multiple parts of the healthcare system, we can't exist as single patient encounters any longer. It just doesn't, we don't have the infrastructure in this country for that. And it's also not the right thing to do for the patient. Yeah, when you think back about this idea of the triple aim, and that's sort of ACA going back about a decade now. We used to think about the patient getting better. Now we're going to think about the patient getting better, what the value in the system for that, what that better means. How do we define what better is? And also not just the patient, but the population of people too.
Very interesting. So do you think, given those changes that were already in the works and given this pandemic, do you think we're going to see a big change in medical education going forward?
That's a great question. So not only medical education, but let's talk a little bit about the pre-medical education that you and I have worked on together. We recognized a while back that we were worried that our medical students weren't being prepared perfectly for the world they were going into. And that sometimes by the time you get into medical school, or especially into medical residency, things are moving so quickly, and you've got so much medical information to learn, it may be too late to develop the lens you may need to develop to be geared for this healthcare system. So as you know, the class that we bug you every year to come and help us teach, Robbie Bear and I do this course where we have pre-medical students come in early, get them involved in patient shadowing, really trying to understand things through a patient-centered lens, and then also participating in mixed methods qualitative research in a very engaged way. So they're doing all these things that traditionally we think about doing as pre-medical students, physician shadowing, being in a clinical space, thinking about research, but we're also sort of sneaking in, transparently sneaking in, but sort of sneaking in this other lens that we hope is going to help about understanding interdisciplinary teams between social scientists and physicians, understand how to kind of view the world through a patient-centered lens. And now we started to translate that into the medical school itself. Robbie Bear and I taught an elective this year to the medical students, having them do some of the same type of work and focusing on some of the structural determinants of healthcare. So I think it's going to change, Eric. I think we're going to see, focus on pathway building, crisis leadership, how we think through problems like this, more emphasis on critical thinking through these types of problems, not to mention or even get to just the logistical, how do you train medical students when you have unsafe populations you don't know the medicine about, right? When I trained as a medical student, we had HIV was still very big in this area. TB was actually on another spike, and so we were exposed to those viruses, and we did see those patients as medical students. But the difference was that there was already over a decade, or TB, over 100 years. But HIV, even the early 2000s, there was 20 years of experience. But now we're seeing patients where we don't understand the virus, and we're having to kind of balance ethically the pedagogy of having a 22-year-old student who's still kind of figuring out what they want to do in medicine life, come and see that patient too, or not see that patient too, whether that's the right thing. And that's the struggle right now. I mean, it's a struggle for you guys too, as educators, right? How much can we expect of stressed out young people who are trying to figure out where to live and during this time, and trying to deal with Zoom technology just like we are, but to also see patients potentially put themselves in a risk situation, not to mention the fact that might burn up more PPE for the physicians who have to go see the patient, right? These are logistical concerns too. So there's a lot there that we're going to have to figure out, I think.
Yeah, that's really, really important, I think. And, you made me think of something, Jason, when you talked about exposing some of these younger people to patient-centered care. One of the things that they almost immediately discover, especially if they're in a metropolitan area, is they get their big, strong introduction into health disparities. and some of the things that are on the top of mind for everyone right now, which is that we were in the middle of a pandemic, and now we are, as a society, reckoning with racism and what we can do about racism and how it plays out in health outcomes and health disparities. Have you thought a lot about that, and do you have kind of a perspective on what it means to be doing the work that you're doing against the backdrop of this sort of monumental social movement?
That's a great question. So I would go back to the way I answered that first question. Previous to this pandemic, it was sometimes difficult to verbalize what one thing had to do with another. I think, not that I'm saying there's anything good coming out of these two clashing pandemics or epidemics, but if we were to find a silver lining, I think the silver lining would be for people who don't think about structural causes of healthcare differential outcomes. I think it becomes more obvious now. It's in our face every day. It's hard to deny that there are some systemic and structural events taking place in front of us. So, having to, in medicine, it's very interesting. The discussion around racism and structural violence often moves to discussions about diversity and recruitments of diversity. These are very, in my mind, they are related but separate discussions. And we've done a good job of recognizing the lack of diversity in medicine over the past decade or so, but not done a great job, I don't think, of recognizing how structural forces lead our patients to see us and how structural forces lead to differential care. I think if you look at some of our medical societies, they've all had sort of, I would say, niche specialty groups for things like structural determinants, or even in my emergency medicine society, there's a climate change and health outcomes, section.
Right.
And, it's kind of a couple other people like me, basically, who had some background in some type of social science, usually, or some type of liberal arts background, and are maintaining some interest. But I think that it's becoming much more obvious to people that these things affect our patients' health and our overall population health. And I am seeing a renewed interest. Just as a concrete example of that, the Morsani, Medical School is doing much more right now on trying to get the faculty up to speed on what these issues are. There's engagement there. Heidi Castaneda and Robbie Baer are going to be hosting a workshop for our emergency medicine core faculty in August around what these issues are and what they mean, just to make sure everybody is up to speed with where this is, so we can start to address some of the root causes.
Yeah, I think a lot of people, even very, very educated people, sometimes the nature of structural violence and structural causes is that they're hard to see, right? Because they're built into your taken for granted reality. And unless you have direct experience with living in a food desert or a risky climate area, a flood zone or something like that, you don't understand necessarily how that might affect, health outcomes. So one of the things that I have to ask you about, Jason, because I'm sure everybody on the call is hungry for this kind of information. So there you are in the front row of the pandemic, and I know this keeps changing, but I have to ask you, what is your current take on sort of the nature of this disease, where we are, what people should do to protect themselves, how transmission is happening? Can you give us any sort of facts of the case, clinical facts that would help us do some level setting?
Yeah, and I'll do it kind of through a perspective where I think I could use your help overall. And what I mean by that is, if I go back to March and April, everyone was attuned to COVID. Everyone was paying attention. Everyone was very concerned. Everyone wanted to make sure we had a good action plan. Everyone was worried about what we were going to do as a hospital. And I think what's happened is that as a society, we have now kind of shifted into a place where we're sort of over it. Some social events have happened that have helped us get there. Certainly, there are some competing interests for how long we can do one public health measure. Let me unpack that for a second. When I think of how we decrease transmission or mitigate this virus, we have a toolkit. We have a number of tools in that toolkit. Vaccine right now is not one of those tools. Medical treatment is really, we have supportive care, but we don't have a specific medical treatment either. So we have to take those two tools off the table. So what we're left with are a number of other tools that help us decrease the transmission of virus. Those tools are hand washing, not touching your face, social distancing more than 6 feet, staying out of groups with more than 10 people, doing safer at home. wearing face masks, and contact tracing. I would say those are probably the major tools we have right now. So for a couple of months, we did safer at home. Now, of course, it has economic and mental health ramifications that are important. We cannot ignore. Those are significant. You know, from a hospital perspective, if we think about what that means, it means that from an economic side of things, surgical volume goes away, right? And of course, surgical volume is, at the end of the day, what kind of pays the bills in the modern healthcare system. And so if you don't have surgical volume, at some point, you probably run out of funds. Now, the other piece of that is, you know, from a patient center perspective, they need to have operations, surgeries, procedures. And we saw during March and April a drastic decline in our ER volume. You know, the ER volume dropped by over 50%. And these are not just the 50% of people who maybe don't need, kind of there's this myth that a lot of people who come to the ER don't need to be there, and that there are some of those people, but I would challenge as to why are they there, but that's another question. But a lot of what we didn't see were the heart attacks and strokes and very sick people as well. And we did see some rising death rates from that. Mm-hmm. So, you know, right now where we are is we're trying to get, I think, a lot of attention back from the public, those of us who kind of live this every day, attention back from our policymakers to recognize, I get that you wanted the virus to happen in March and April. I get that you wanted to get it over with in March and April. But unfortunately, the virus doesn't really care what you think, and it's arrived now. And so the positive of that, Eric, is that we had some time to prepare for this, and we got good at some things. Mm-hmm. So in March and April, we got really good at understanding, for example, testing. So we have a pretty good understanding of testing in our hospital system and throughout this whole area. So we're talking about Advent Health or Baycare, HCA, or Tampa General, those kind of your major hospital players. We all have a pretty good idea of how much testing each person has, what type of testing are you doing, is there a false positive rate? And by the way, the PCR testing, the nasopharynx testing, very low false positive rate. It's more of a false negative rate we worry about this. So if you're positive on that, you're positive. So understand that capacity, getting a hold of the virus and defining it that way.
And Jason, that's the test that pretty much everybody is getting, right?
Correct. Yeah. So the kind of uncomfortable one, which I've had twice. So it's not horrible, so I don't scare anybody. But you know, not exactly pleasant to stick something way back here for about 20 seconds or so. But that's the test that, and I bring that up, Eric, because there's some talk in the public discourse and the media right now about whether we can trust test results and what do they mean. So I want to make it clear that a positive PCR test is a positive PCR test. We really believe that's a true positive. Now, if a person's not spreading virus around right now, or if I don't stick that little stick back far enough, I might get a negative test. And so I'd be much more worried about undercounting than I would be about overcounting. So we got good at things. We got good at as a healthcare system about working as teams with our public health colleagues, our infectious disease colleagues. We figured out safety plans. It's still safe to come to the hospital. I think all the hospitals in this area are actually safe to store right now. And so it's very safe to come to the hospital. The people who have COVID are going to be, sort of cohorted off to a different space, and people who don't will be in a different space. And so that part's fine. So now, though, the issue, of course, that we're seeing is in March and April, most people who came in with COVID, we kind of expected that, right? They were older people who seemed sick to us. And so it wasn't a shocker when we got a positive COVID test on them. As a matter of fact, we tested thousands of our Tampa General frontline staff. And of those people, only a very few of them had antibody to COVID, which means they might have been exposed to COVID without knowing it. So there wasn't much asymptomatic spread going on, and overall we were pretty safe in terms of how we were taking care of patients. What's been enormously interesting from an epidemiological and clinical standpoint, though, is this shift that's taking place, and I will say from a social science standpoint as well, because who gets sick is a very important question, right? What structures put a person in place to get sick, right? So what we are now seeing instead is a massive increase in pre-symptomatic or asymptomatic spread amongst much younger people. So the median age of diagnosis has shifted from the 60s down into the 30s. The people I'm seeing every day right now has skyrocketed for sort of the either service industry workers, and again, I would offer there's a lot of historical racial structure around service industry workers. who need to go to work in a place where they interact with other people without PPE on, right, to make a living, but also young people who are sort of moving into crowds, right, to do what young people do, which is to socialize, right? So that's really where we're seeing spread. The problem with that, Eric, is that the more of that pre-symptomatic, asymptomatic spread we're seeing, and we're seeing a lot, by the way, just to give you some idea in terms of numbers, we have a site we use at the hospital for patients who are sick, who come to the hospital and need to be tested. And that number of people who've started to come in has skyrocketed sometimes into the hundreds per day.
Mm-hmm.
So we've really seen an increase in this past 5-6 days or so of those people seeking diagnosis. And the positivity rate, this is also important, is around 14 to 15% right now. Wow. So in other words, even though we're testing more, the percent that are positive is also going up. So this is not just because we're testing more, we're finding more positives, there's more out there as well. And the concern with that, of all these young people having it, is that about 20% of people who have COVID are going to get sick. And of those 20%, another way to think about this, about 120 out of 125 people, we probably have one death out of every 125 people. So the more asymptomatic, pre-symptomatic spread we see, the more we get concerned about that. And right. While our ICU numbers throughout the entire area have not reached capacity yet, we are beginning to become concerned. Hospital volumes across the area have increased, and they are continuing to increase, and we are becoming concerned about that overall.
Okay. Well, let me ask you about this. This is a little bit different, and it's not really your area of expertise, but I'm sure you've thought about it. What do you think is the role of government at any level to try to prevent or curb future pandemics in promoting public health? And you've been watching the city, the county, the state, and one of the conversations that you and I have been involved with the county lately is the whole question of asking people to take protective measures, limiting their personal freedom and liberty. Are you asked ever to think about that, or do you ever take a position on that? I know that hospitals a number of years ago started forcing everybody to get flu shots, right? For example, how do you think about that? Is that a real tension, or is it not something that you really want to think about?
No, it's something I think about all the time. I think it goes back to that conversation about tools in a toolkit, right? And so that conversation about what tools we have in the toolkit to utilize from a public health perspective is related to what do we want out of a society, a democracy, right? So we sort of have this, tension agreement with rights versus needs, and what we're going to kind of, accept to be some invasion in our privacy or in our restriction of our freedom. And there's some trade-offs that have to happen. That's kind of where public health interventions sort of start to come into play. Mm-hmm. So, if we think about safer at home being kind of one extreme of a public health intervention, that we, meaning like us as a society, have decided we can't tolerate at this point of time any longer for a number of reasons, economic, well-being, social, whatever, then okay, we also now in a democracy have a responsibility to say, well, what are we going to do instead? Because this is our decision in a democracy. So we can't be babies and just say, we're not going to do safer at home, we're not going to do anything. I think we now have a responsibility to say, we're not going to do safer at home, here's what we offer instead. And I would say to that, we have other tools if we're not going to do safer at home, right? So the other tools in that toolbox are continued hand washing, social distancing, staying 6 feet apart from each other. And of course, I'd say the one that's been the media the most recently that I've been involved with at the county and state level and had to make some decisions about this is face coverings and mask wearing. So early in this pandemic, we did not have a ton of data that said that face coverings or masks helped. Now, of course, what happens when you have a pandemic that touches billions of lives is that you get a lot of data very quickly. And now we have, from a Science article, a Lancet article, other articles have come out since then, but rapidly getting more and more data that shows a clear benefit of facial coverings. So if we're not going to stay at home, we have to accept that we are going to do some personal responsibility pieces of this, which hand hygiene, wearing a face covering, that's going to be on us because we as a society have rejected another intervention, that's fine. That's our right as a society. Now, I say where this starts to get really interesting and a little bit stickier is if things keep on going how they're going, which means cases are still going up rapidly, there's another discussion we have not had yet, which we may need to have, and that's a discussion about intensive aggressive contact tracing. So if we look at some of the societies that have done a really good job, South Korea is always a great example. They flattened and destroyed the curve. They started out where the US did in terms of number of cases on the same day, and then their curve bent, flattened, and just got steamrolled. Now, they had face coverings very early. They relaxed social distancing, but with that relaxation of social distancing came contact tracing. Now, contact tracing, we think of as kind of a manual thing. Some people at the Department of Health trying to do this, interview, trying to figure out where you were. What we've learned is that that's not always adequate, and it's also highly labor intensive. But, we all walk around with one of these that has a lot of data on it already. And where we've really seen success in other countries is utilization of that data to essentially make sort of data decisions for you, create sort of networks of where contacts are, and then use app push notifications to say you are around a person who is exposed, you're going to need to be tested on this date, or you're going to have to isolate at home for X number of days. So this kind of tension and trade-off of what we want to do, I think, may be necessary when we have that contact tracing discussion. We haven't had that discussion yet as a local area, but if cases keep on rising and we don't want to do safer at home, that might be coming next, for example.
Very interesting, and I love what you did there. You're comparing face coverings to safer at home, so it actually becomes a way to be able to get out more, right? By making that contrast. It's interesting. You really can see the overlap in public health between sort of the clinical advice and sort of the political environment that we're living in right now. Because actually, I know Dr. Malarkey talked a little bit to the emergency policy group a few months ago about contact tracing through cell phones as a way of curbing and flattening the curve. And there was a small percentage of people who responded very negatively to that because of just sort of a general mistrust of government's ability to do things. So I think that's interesting. Let me ask you this, Jason. You have become very present on social media. I see your work on LinkedIn. I see your work on Facebook and other places. How has social media helped you do your work during this period?
Yeah, that's a great question. I think one of the responsibilities we have, whether you're doing your work or me doing my work, I think we have to communicate back to the public, what we know and what we see in a way the public can understand. And so, obviously social media is a platform that's easily accessible, that you can kind of unpack things in. And, I think the nice thing with that is I can use the language that I would like to use to try to make kind of complicated topics digestible. So if I write for a scientific journal, which is also important in my career, right, that's going to use different language that, may not be useful for people who don't do science or this every day. So I think the other thing about social media is what I've recognized and realized is if I don't put it out there, someone else will. And it doesn't mean that I'm the person, but there is a vacuum of information and people want information. And we've seen some really dangerous information go out on social media. There were 2 physicians in California who've been reprimanded by their professional society for basically saying the virus is not a big deal and is a hoax. But this kind of stuff, there was a anti-vaccine sort of documentary type of style YouTube thing that went out with really some pseudo facts. So these things will go out and propagate if I don't get things out. And so I feel like I have the ability with social media to use graphical representations and easy language of complicated concepts, break it down, engage, back and forth a little bit with the public, because there's some reasonable questions for people who haven't thought about this stuff all the time. I remind myself all the time, for the last 20 years of my life, I've thought about this stuff every day in some way, shape, or form, and so you need to unpack this stuff for people who come to the table at least genuinely engaged.
Well, I'm really glad that you're doing that work. I think it really has an impact. So, Jason, I want to now open up for questions from the audience, and I think we already have a number of really interesting questions that have come in. I want to turn over to our moderator, Kelly Addington, who's the Senior Director of Development and Alumni Relations for the college, who is going to let us know what those questions are. Kelly?
Thank you so much, Dean Eisenberg. Thank you to you both, Dr. Wilson and Dean Eisenberg. This is a really great discussion, and we've got questions coming in. And so I just want to remind everybody to ask a question or post a comment. You choose the icon with the question mark and type your question into the chat box. And we are viewing the questions that have the most likes first. And so I will start with a question for Dr. Wilson that Dean Eisenberg may want to contribute as well, as it is related to the University of South Florida. So Dr. Wilson, what are your thoughts on USF's reopening plan? Do you think, in your opinion, should classes remain online, go to face-to-face? What are the risks worth? And realistically speaking, can we expect young people, which is a large portion of our student population, to adhere to social distancing guidelines and comply to mask wearing?
Yeah, so I'll answer part of that, then I'll turn it back over to Dean Eisenberg to answer some specifics. But what I do want to say, though, is that of all the plans I've looked at for the state colleges and universities, is that USF seems one to be the most well thought out. And having some of the background information to know some of the people who've made those decisions, I will say that it's been pretty impressive to see how much time and effort's been put into thinking about this. So both Dean Eisenberg has worked really closely with a number of experts throughout the college and the university to try to gather the right information to make the best decisions. Dean Patterson over in public health has really thought through this and is on daily calls and meetings with us to try to think through the best medical advice that's out there right now. And I'll turn over to you in a second, Erica. The one thing I would say too is that young people are actually overall a pretty supportive group of people in terms of trying to do the right public health strategy. We actually have an ongoing survey that Robbie Bear helped us design at Tampa General in terms of mask wearing and other social distancing strategies. And if you look at the mask wearing crowd, even before the ordinance and both the city and the county ordinance passed, mask wearing skewed towards the younger 20 to 30-year-old population as a very heavy supporting group of mask wearing and people who said they always wore a mask. That's ongoing data we're collecting right now, but I don't have any worry about them being young to participate in good public health strategy.
Yeah, I can speak to that too. Of course, I think our reopening plan was just approved by the Board of Governors this week, so it's all happening very fast. The first thing I'll say is I think Dr. Wilson is right. We are fortunate to have really world-class experts in the medical school and in public health to guide our plan. Sort of the core idea behind our plan is that if someone is vulnerable in any way, they don't have to be face-to-face. And so I think that that's crucial. And what that's done is it's really sort of forced us to upgrade our technology and really raise our game around delivering online education at a very high quality. And so some percentage of courses will be offered face-to-face. We're certainly going to try to do that because we know that students very much want to have the face-to-face experience, as do many faculty. But it's like Dr. Wilson has been saying, we have to do that in the safest way possible so that we don't put people at risk. And so far, I think the plan is good, but the caveat there is that a lot of it depends on what happens between now and August. And if we're able to get people to wear face masks, social distance, and if we're able to stop the sort of rising in cases in the area, I think we're going to be just fine. But this is, I think Dr. Lockwood said the other day that anytime you look at data, you're taking a still picture of a moving train. And, you know, the train is moving, things are changing, and we just have to be very nimble and flexible. But the thing I will tell you is that there is nothing more important to us than the safety of our students, faculty, and staff, and also helping our students to be successful. And so, you know, we're going to try to balance those things as best we can. We're going to spend millions of dollars on face masks and cleaning and deep cleaning of buildings, signage, technology, all those kinds of things.
Thanks to you both. Okay, so our next question is directed towards Dr. Wilson from our good friends Peg and Art Silverglide. Has the clinical presentation changed now that a more significant number of younger people are presenting?
Yeah, that's a great question. So the big change we've seen is that we have many more people who are essentially asymptomatic or have very few symptoms. So now we can start to really think about COVID as a syndrome versus being infected with the SARS-CoV-2 virus. So COVID as a syndrome has some similarities to it. COVID as a syndrome makes it harder to breathe, decreases your saturation of your oxygen, the ability to actually get oxygen on your blood cells. And then as the virus progresses, has sort of a second phase of inflammation where we see a lot of discomfort with a lot of inflammation like chest pain or even rashes or even extremity sort of injuries from this vascular damage that is happening because of the inflammation that's occurring. So we've learned now there's probably two phases of the virus, both as the virus replicates and spreads, there's some disease and sickness around that. And then also as that spread happens, as the inflammatory system mounts up, some inflammation around that inflammatory cascade. Now, the young people that we see who have this, certainly more of those people are able to just simply have the physiological reserve to withstand a lot of that without ever really getting sick. And it was interesting because in Tampa, in this specific area, we were all a little confused, to be honest. Back in March, we would see these reports coming from New York and Italy about all this asymptomatic spread. And we had so much data that was not happening for us. I mean, we had the hospital workers, we were doing some community, testing, surveillance. We were starting to test everybody in the hospital, period, no matter what you were there for. And we really weren't finding any positive cases. So when we were hearing about people without symptoms, we were pretty confused, but that's the thing that's changed. Now we're seeing that. Now, there are a couple of, even the people with not many symptoms, if you really dig, there's a couple of things that seem to be much more prevalent, not always there, but more often there, and that's changes in taste and smell. Even our young people seem to have some change in taste or smell, which is pretty interesting.
Thank you so much. Now we have our second most popular question thus far. Again, this is for Dr. Wilson. Would you recommend taking an antibody test, or do you think that these tests are inconclusive and unreliable?
That's a great question. Okay, so I'm going to unpack testing really quickly here, okay? So there's two reasons we do testing. There's to diagnose you with something and to understand the public health disease better, to surveil the disease, okay? Now, to diagnose you with something, the kind of gold standard at this point test is the what's called PCR test. A PCR test utilizes DNA technology to try to amplify the amount of viral particles, RNA technically, viral particles that we see on the surface. We try to amplify that up. That's the gold standard test. That's a very good test. Now, from a diagnostic perspective, there's a little bit of use of rapid antibody testing out there, but the sensitivity is lower, the ability to get a positive when you're really positive. So we're not using too much of that. What a lot of the antibody testing that's going on is people who feel okay, just want to know if that cough or cold or fever that they had back in March or February or January, was that COVID? And they want to go get antibody testing. Now, here's the problem with antibody testing. It's not that the test is necessarily a bad test. The problem is, it's going to get a little clunky for about 30 seconds. The problem is that when the amount of disease out there in the population is not very high, when there's only 1% per se of the people out there in the population have disease, that means that the false negative rate might match. In other words, if the people out there who have disease is about 1% and about 1% of the time my test is inaccurate, that means that if I get a positive test, it's a fancy term called a positive predictive value, it ends up being about a flip of the coin, whether or not that test is what's called a true positive or not really a true positive. So overall, unless there's a specific reason why your physician needs you to get that test, it's probably not useful for all of us to run antibody testing right now. We know what things look like, I think, at this point in March and April. And so if you have symptoms right now, or if you're concerned for some other reason, you need to have a surgery or a procedure, or you have an immunocompromised person living with you at your house, then it's fine to go present probably for a PCR test.
Okay, we're going to keep it on the symptoms and testing question. And again for Dr. Wilson. And I want to say, I love how you take those fancy terms and break them down. So next question.
I don't know if I should see it on that one. That one stayed a little clunky, so I'm sorry.
Flip the coin. All right. So the next question is also related to symptoms and taking temperature. So why should we take a temperature before entering a place, since symptoms can appear anytime during a 14-day period, and some people don't develop symptoms and test positively?
Great. Also a great question. So here's how to think about public health strategies. Not every strategy is going to catch every person who has disease. Not every strategy is going to prevent every problem. So in other words, we see a lot of car crashes. For the most part, if you wear a seatbelt and you're in a car crash, you'll probably survive the car crash. Do people die in car crashes who wear seatbelts? Unfortunately, yes. But it sure does cut down on a lot of those people. So think of it the same way. If I do massive temperature check screening and symptom check screening of people, I'm going to catch some virus there. So that's another tool in my toolkit to bring some of the people with virus out of the population before they enter a crowded space and can spread more. Am I going to miss some of those early pre-symptomatic, asymptomatic people? Yes, I am, which is why we need other tools in the toolkit like contact tracing, mask wearing, everything else we talked about along with that.
Okay, thank you. Now, here's a question that, a lot of people have been talking about the mental health aspects, and this is somewhat related to college-age students. So I'll direct this to Dr. Wilson first, and then Dean Eisenberg, you may also want to weigh in, is that looking beyond the number of COVID cases and specifically at mental health effects on communal society, how is this affecting college students who many of them rely on being a part of a community?
Yeah, it's a great question. I mean, I'll speak from just the experience I've had teaching this last semester. I'll turn it back over to Dean Eisenberg to pick up on this. But I teach a honors thesis course in the spring, and all of my honors thesis students, the unique thing about the students I take, they all get to usually do direct patient, some type of patient research. And so they're in the hospital setting, talking to patients, getting data about patients, learning what it's like to do patient interactions. And of course, that was all stopped, not to mention our medical students, right, who also have not been in a clinical space for a long time. Now we have found some ways for them to still, I think, contribute value. And I think, and I'll turn over to Eric in just a second, but I think in my mind, if you can find a way for people to still know that they're contributing value and know that their education is still occurring in a real way, I think you have a lot of ability to still maintain some wellness there. That's why I found the honors thesis course, because we use those students to help us with COVID resulting, to help us think about some of the COVID data we're bringing this. It seemed like a very pressing matter, and I think they were very happy to help with that. Obviously, the social aspect of this, I think we're seeing the results of right now. Certainly, we're seeing very rapid spread in that young age population as they return back out into the wilderness.
Yeah, I mean, my thinking about it is, you've heard some people try to say this, but what we really need to aim for is, just because we're physically distant, we're not socially and emotionally distant. So the key seems to be, as Jason said, to try to continue to remain engaged. And in my community, I've communicated directly with all of our students in the college, and I've told them that, not only is it important for them to stay engaged, for them to make progress towards their goals, but also to stay engaged so that their life makes sense and they're meaningful and they're working towards things around other people, even if it's virtually. And so the truth is, we've had concerns about student mental health and mental health in our society before the pandemic. We've been focusing very, very hard on that, making sure that students don't get lost, and that if they have problems, especially with things like anxiety and depression, that we deal with them. And we don't really know. We've never had a disruption quite like this before, so we don't really know what the impact is going to be. But I think that the best medicine, metaphorically, is to continue to engage students in activities that are meaningful and with their fellow students and faculty.
Thank you. Thanks to you both. I think one of the important things in this, and what we've heard from some of our faculty members in the Department of Psychology, is people's willingness now to have more open conversations about mental health and how we can address, anxiety and depression in ways that, now that we have more people experiencing that, are being open to talk about it. So that's important. We have, just a little plug, we have some great COVID-related research projects happening in psychology around that right now. So the next question is directed to you, Dr. Wilson, in that some reports show people are getting COVID more than once. Is this usual or unusual?
It's actually unclear as to what's going on right now. So what we have learned is that patients can test positive, seem to get better, test negative, and then for some reason have another test and test positive again. And that's created a lot of clinical sort of consternation, but also some operational limitations, right? As we think about trying to move a patient, say, from a hospital to a group home or a nursing home setting, it's not clear to us right now as to whether or not they're truly positive again, or if those people are just simply having viral particles remain with a PCR test that's very sensitive. Now, the other part of this we're trying to figure out is how do antibodies weigh into this conversation? And so we try to test everybody that we have in our sort of population of, say, employees and other doctors who have positive COVID tests. We try to follow them and follow their antibody levels over time. We also follow some of our patients' antibody levels over time. And so one of the promising things is that most patients have mounted antibody to virus. What's a little concerning is that some of that mounted antibody is not very high. And what we're also, I think, not just us, but bigger groups of researchers also you're starting to maybe see some early publications of, is trying to figure out if that mounted antibody starts to decline rather quickly. And if it starts to decline rather quickly, the concern with that is, will there be enough of the immune type of antibody out there the next time that patient's challenged with COVID to kind of either fight off the COVID or just have a very benign clinical course? So unfortunately, I don't have a full answer to that. It's just an active research area we're on right now.
Okay, well, thank you. We can maybe stick to the theme of something that you may or may not have an answer for, but I know a lot of parents who have school-age children are making decisions now about what they'll do when school reopens and in what way that looks like. So, Dr. Wilson, is there a realistic way to restart K through 12 in-person education before a vaccine is created without putting populations at risk?
Yeah, that's a great question. And just so people know, I have an 11-year-old and having the same conversation right now. I mean, as a matter of fact, yesterday, I think the Hillsborough County School Board said you could go virtual, back to school, some mix of the two, dealer's choice. He actually wants to go to school, which makes sense, I think, after an 11-year-old sat in a house for the last 5 months to go see some other kids. So, I won't speak for the school board, but I will say a couple of things here. One is that fortunately what we have seen, very few kids get sick from this. So it's probably not too big of a concern of our actual children getting sick. The concern, of course, is that our children become asymptomatic carriers of disease and bring that disease back home and give it to grandpa, grandma, mom, dad, somebody who's got some immune problems. Now, there's still some clinical debate about even if they might be less likely to get virus than other people. So maybe they're less likely to be asymptomatic carriers. That's still a kind of an ongoing active part of debate. And so all I can say is something that Eric said earlier, what is true now may not be true in August. I think if we had lower class sizes, ways to stagger who's there and when they're there, that certainly helps the kids. I think the question too, though, is what about the teachers, right? And how do we deal, and probably back to Eric too, for how you deal with, teachers who may be older or professors who may be older and have some immune problems too. So I again, don't have a clear answer for you. I know the school board's actively working on these issues right now, just as USF is.
Mm-hmm.
Eric, do you want to comment on that or?
No, I mean, the one thing I will say is that the issue of changing the physical layout of the school experience is a big part of our plan at USF, and indeed every university's plan. And K-12 is going to have to do that as well. And so, we've pulled out plans for every building and all 3 of our campuses, and we figured out, all right, if this classroom holds 80 people, can we put 20 people in it spaced out in a way that they're much less likely to come into close contact with each other? So that's a big part of it too. But I think Dr. Wilson's right. I think that K-12 has the same challenges that college does. The reason why K-12 is so very important is because it's our kids, it's our kids and our families, and it also affects our ability to work as well. So it's very complex in that way.
Yeah. So fun. Okay, thank you so much. Now, we do have time for a couple more questions, so I want to encourage people to keep liking questions. We're not going to get through all of them, so we will go with the most popular. And Dr. Wilson, you mentioned your 11-year-old wanting to get out and about and be with other people, and I think that's something that adults are feeling as well. So in respect to flying, some people think that it would appear that an airplane is the antithesis of what we're suggesting by the CDC to decrease the risk of contracting COVID. Have there been any recent studies of the risks of contracting virus through commercial flights since the country has, so to speak, opened up again?
Yeah, not that I'm aware of a publication. I think there's just not been enough commercial flights, with enough data being kind of drawn on those. I will share those concerns though. I certainly am not traveling right now on a commercial flight. I'll let people know that. If people were to ask me, I'm staying virtual for everything, and I've canceled all flights, and so unless it was a super essential reason, I would probably avoid it for the moment.
Okay. Thank you. I don't like that answer, but thank you.
I know. I like to travel too, so I don't either.
No, just kidding. So, okay, another question related to health and safety. Dr. Wilson, what's the one most impactful thing you would say to someone who's on the fence about wearing a mask?
Okay. So let's go through that for a second, right? So is your consternation, concern, hesitation is because you don't really trust the data, or is it something else, right? So if it's a data issue, then the worst case scenario is you wear a piece of cloth in your face and nothing happens, right? There's no one's benefited, but no one's harmed either. When we think about public health interventions, I think we think about them in terms of analyzing what is the cost, what is the harm, what is the benefit. So essentially with mask wearing, you're almost at a only positive benefit. There's really not much of a harm or a cost. There may be a small percent of people, a small group of people who have trouble wearing a facial covering like this, and that's why I think most of the ordinances you've seen have been pretty broad in terms of what's acceptable for a facial covering. So overall, we have enough data now that we can confidently say that some type of protection, whether it's a cloth mask, a surgical grade mask, even potentially a face covering if you can't, like a shield if you can't wear a mask, all of these things are going to decrease viral particle transmission. So I think at this point we're at a place where we only know we're going to help people. We're not going to hurt ourselves. We're not going to hurt anybody else. So what is the loss?
Okay, thank you. And I believe this will be the last question we have time for before I pass it back over to Dean Eisenberg. And this one's for you, Dr. Wilson, though. Dean Eisenberg, you can take a stab too. What is the current status of vaccine development?
Yeah, I watched Fauci's press conference yesterday. He's still hoping for a 2021. Having said that, he's also a person who's worked in, HIV for the last 40 years of his career. And I'm always very guarded, with vaccine conversations, especially with RNA viruses. I have people I know, colleagues I know, and friends I know who've worked on vaccines, RSV vaccines, for example, for entire careers, and we don't have one. And a few promising starts and stops with HIV vaccines, and we don't have one. So the positive, right, is there's a lot of smart people working on one problem at the same time, which is obviously helpful. There's been some rumblings out there of a couple of different large pharmaceutical companies that are getting close to moving past a phase 1A trial, moving to the next phase of trials. But just keep in mind, that's not even a trial to show a benefit of disease lowering chance of spread yet. So I'm always guarded there. Fauci is obviously I think a fairly transparent and trustworthy voice right now in the public dialogue. I'm glad to hear him say he's hoping for 2021, but I would still have some skepticism around that.
Okay, thank you. Dean Eisenberg, I'm going to hand it back over to you.
Okay, great. Thank you, Kelly. And Jason, thank you so much for all those answers. We're just about out of time. I want to give you a chance, though, Jason, if you want to make any final comments. Again, the purpose of these sessions is to sort of showcase, what education can do for someone in their career, and in particular, in this case, the broad-based liberal education that you have and how it's informing the way that you're working. Is there any sort of summary comment that you'd like to make about that?
Sure. I would just basically say that even pre-pandemic, it's really colored the way I do my work. And what's been really nice is at this point in my career, I think I've formally integrated a real social science, College of Arts and Sciences type of model into how I see medicine and do medicine. So at this point, we have a postdoc anthropologist working in the clinical space in the emergency department. We have a PhD student in the clinical space working in the emergency department. We work really closely with a number of the anthropology faculty. I started working with one of the criminology faculty now, thinking about things like human trafficking and other, types of abuse and crime, and even, things around police and the structural racism, that's conversations ongoing around that, how we can both engage our law enforcement community through our criminology department and also our patients we see in the ER. So these conversations don't take place, I don't think, without understanding that lens and that viewpoint and integrating this type of education into medicine.
Well, Jason, I can't thank you enough for taking the time to share with us today. We've all learned so much, and it's just been a pleasure speaking with you as always. And all of you who've been on this broadcast, I want to thank you for taking the time to join us. We're going to keep doing this as long as we have to until we can get back together face to face. I hope that you'll join us next time. Until then, I wish each one of you personally, please take care, stay safe, wear your mask, and go Bulls.